One of the concerns raised by the SWOG study that I talked about earlier is the fact that obviously adding bortezomib to the Lendex doublet, significantly increased toxicity, and I think peripheral neuropathy, was a significant concern in that group of patients. First off, the bortezomib was given intravenously in the SWOG study because patients enrolled prior to regulatory approval of subcutaneous bortezomib. So I think the use of subcutaneous bortezomib will help ameliorate the risk of neuropathy. I think a lot of us have started moving to kind of a modified RVD type platform for the older patients that may be more prone to side effects, including peripheral neuropathy. So, from my standpoint, I'll sometimes use a 28-day cycle as opposed to the 21-day classic cycle, where I'm giving the lenalidomide perhaps at a 10 or 15 milligram dose initially instead of 25 for 3 weeks out of 4, giving the bortezomib subcutaneously on a once weekly basis, and giving the dexamethasone on a once weekly basis as well. For those patients that are 75 years of age and older, or for patients who have brittle diabetes, congestive heart failure, I would lean towards a 20 milligram dose of dexamethasone as opposed to a 40 milligram dose of dexamethasone. So you can adjust the schedule of administration, the mode of administration with regards to bortezomib, and the actual dose, and all of those things are important as far as ameliorating toxicities. And that's important because, again, this continuous treatment paradigm appears to be advantageous, at least with what we have available to treat patients now. So we need to minimize side effects if we're going to actually treat patients continuously.